Hello, friends and fellow surgeons. Welcome back to Inside the OT. In this video, we're going to look about laparoscopic myotomy with Dor Fundoplication for a patient with achalasia cardia. This patient underwent endoscopic dilatation twice elsewhere, which was failed, and she started developing symptoms of dysphagia yet again. So I've planned for a laparoscopic myotomy in this patient. So basically, the aim of Hiller's anatomy is straightforward, where we have to divide the muscle fibers of the lower esophageal sphincter and create basically a low resistance pathway for the food bolus to pass. So let's get through the operative video step by step. First is the patient positioning. The patient is typically positioned in supine with leg split, where I'll be standing in between the legs and my assistant will be to my right, with the lap stack placed right behind the left shoulder of the patient. So the port placements remain the same as for standard upper GI ports. So after doing a diagnostic laparoscopy, we start our surgical proper. So the first thing is the pars flaccida approach of the gastrohepatic ligament is opened carefully. This gives us an access basically to the right crus and allows us to define the hiatal anatomy. So over there, I'm taking down the phrenoesophageal ligament as the right crus is already exposed. I'm taking down those phrenoesophageal fibers. So by taking down these phrenoesophageal fibers, you'll get exposed to the lower part of the distal esophagus. And now I'm running my harmonic over the right crust to create a retroesophageal window, as this forms the landmark step in case of any hiatal repairs or in case of any myotomy repairs, because creating a retroesophageal window will adequately mobilize the fundus and it will help in a safe wrap creation. When you do the retroesophageal window, you have to be more careful about your posterior vagus nerve, because there's always a chance that we end up sweeping away the posterior vagus. Instead, we have to sweep the posterior vagus towards the esophagus and lift it up altogether. So these are basically, like I said before in previous videos, these are the embryological planes. Basically, is a bloodless field where you can create the planes. Once you have done a retroesophageal window, our next step is for the esophageal mobilization. So you have to mobilize adequately 5 to 7 centimeters of the esophagus. So the reason for mobilization is to obtain a good visualization and for a proper controlled myotomy. I'm taking off those last few phrenoesophageal attachments to mobilize the fundus. You can see I'm working on the left crus and mobilizing the esophagus off the left crus. So you have to, care has to be taken because you'll have your anterior vagus running in the close proximity. Make sure your your active limb of the harmonic is not facing the esophagus, because the active tip can injure the nerve. So these are the final few attachments of the left crust to the esophagus. So once you've circumferentially or 3/6 circumferential mobilization of the esophagus is of utmost importance, because you don't want undue traction by these structures where it will pull the esophagus up, and it'll lead to a wrap disruption in the postoperative period. So there should be you should have utmost patience when you do this esophageal mobilization. There are various reasons for that, because one, your successful surgery depends on the well mobilized esophagus. Number two, um, there are minor blood vessels which will be running on either side of the esophagus to the thoracic part. So we have to be careful, and minimal dissection should be given. There shouldn't be any untoward or extraneous retractions, or basically you should respect the tissues. That's what I'm trying to tell. Once you respect the tissue, once you move your movements, once you make clean movements, you'll have a really good bloodless field. So I'm just taking down those few attachments of the fundus to the left crus. So we need a complete fundal mobilization. We don't want any of these posterior attachments, which gonna pull your wrap and which will end up in a wrap disruption later on. So now that the fundal mobilization is almost done, our focus is shifted towards our thoracic part, where we have to identify the anterior vagus nerve. The reason why we have to identify the anterior vagus is when we do the myotomy, we don't want an inadvertent injury to the nerve and then lead to the nerve transaction. So that is your anterior vagus nerve. So you see, I'm like reaching to the root where the vagus divides into anterior and posterior. So it's better to identify the nerve a bit proximally than distally, because distally your nerve will branch out, where proximally you'll just have one single trunk. That's what I'm trying to do. So yeah, now that I've identified the anterior vagus, I'm just going to salvage it by lateralizing the nerve. Why do you have to do this? Because the nerve runs anteriorly, which will be close to your myotomy site. So you want to make sure that you're going to safeguard the nerve. So yeah, this procedure actually requires, careful dissection and good anatomical orientation of the structures and meticulous, preservation of the nerves. So once you achieve that, or you'll have a successful procedure. Now that I'm, mobilizing this anterior vagus, yeah, there will be minor bleeds. Whenever it bleeds in this point of time, never use an energy device because you'll have your esophageal serosa close by. Just give compression, that's enough. So once you have mobilized your anterior vagus, the next step is to identify the gastroesophageal junction. How do you identify it? These are the fat called the Belsey's pad of fat. So I'm just mobilizing the Belsey's pad of fat, where my assistant is pulling one end of the fat to the other side, and I'm with my other hand pulling it out. So see, now that I've mobilized the Belsey's pad of fat and I've identified the GE junction. So again, this step is a rate limiting because your myotomy should always include the cardiac part of the stomach. That is why we call it as a Heller's cardiomyotomy instead of just a plain Heller's myotomy. So once that is done, next we're gonna jump into our myotomy proper. So how do we choose the site of myotomy proper? So I usually start from the lower end of the esophagus and advance proximally. So I generally used to use a Maryland and a grasper. If you have another extra Maryland with you, it'll just help you out. So over there, I'm slowly doing my myotomy by dissecting the muscle fibers, those longitudinal and circular muscle fibers. As this case is already, esophageal dilatation is done twice, I was expecting a bit of fibrosis, but I think God blessed me well and lucky enough that there's no much of fibrosis seen. You can see the mucosa is popping out, so there's a clear difference now you can observe. Your mucosa is popping out when you separate those muscle fibers. And one more tip over here, when you do, obviously, when you cut any muscle fiber, there will be some bleeding. So you don't have to panic when you bleed. If it bleeds, you just have to, use a good gauze compression. That's more than enough. And make sure you don't use any energy device. If at all you use an energy device, you can use a harmonic. Make sure your active tip is not facing towards the mucosa. Instead, it's either way. The active tip should be placed over the serosal part of the esophagus. So these are the few tips where how you have to do a proper esophageal mobilization. One more thing using a Maryland is you have your curved part where you can create a tunnel in between the mucosa and the muscular layer, which will help you in case of the myotomy. So you see, I didn't use any energy device here. because a proper graded muscle retraction can create a very good esophageal myotomy. Now shifting to the cardiomyotomy. So basically the length of the esophageal myotomy should always around be 5 to 7 centimeters, and the cardiomyotomy is again around 2 to 3 centimeters. So the total length of your cardiomyotomy should almost be equal to 9 to 11 centimeters. So I'm just doing the cardiomyotomy where we can see the circular fibers of the stomach, which is coming into the play. So again, you'll have your left hepatic artery in close proximity here, which you have to be more careful of. And second thing, your anterior vagus. I forgot to tell you. So when you do the cardiomyotomy, always make sure or have an eye on your anterior vagus to not to disrupt it. So, and one more trick here, you can see my assistant, he is pulling the fundus to the either side, or he's pulling the fundus in such a way that he keeps the lower esophagus in tension. So now I'm checking the mucosal integrity, which is nothing but a air insufflation test, where I'll ask my anesthetist to push the air through the Rayleigh's tube when I fill the Hiatal area with the submerged in saline. So now the next or the final part of the video is your creating the wrap. So carefully observe here. I'm first taking a bite on the esophageal musculature on the left side, then on the left crus. Then you see I'm gonna take a bite on the anterior surface of the fundus, which is close to the angle of his. I'll come back to you why creating a wrap in this manner is important. So again, the reason for adding a partial fundoplication is that it's basically to reduce your postoperative GE reflex. Now that we have disrupted the lower esophageal sphincter, we have disrupted the musculatures. There will always be a risk of your reflex disease, right? So for that, you have to add a wrap component to prevent the reflex. So I'm taking another bite again on the musculature. This time I'm not gonna use hiatus here. I'm just take the musculature and your anterior surface of the fundus. So I'm using a 20 ethibond suture. Again, there are few people who use ethylone and few people who use proline. So now the same steps are followed on the right side. Take a bite on the right crus, then on the musculature which you have divided on the right side of the esophagus. Then this time we're gonna make a wrap so that we're gonna take on the extreme part of the fundus. You see? So yeah, that is the extreme limit of your lateral limit of the fundus. So this will create an anterior wrap. Now I'll tell you why we have taken the bites on the right side and the bites on the left side instead of just standard wrap creation by taking it on just on the right crust. The reason is, the bites on the left side will keep your musculatures away from it and prevent post-operative muscular band formation. So there's a reason we have taken both the anchoring bites on either side to make your one to make your sphincter away from it to prevent it to form a band in the later part of the time where patient which will lead to a failed operation on a later period. So now that wrap creation is almost done, the fundus is secured appropriately to the edges of the anatomy side, and I'm gonna take few of the anchoring bites to the hiatus and to the fundus to prevent it to disrupt. So these are a few, tips of how to create an anterior Dor Fundoplication wrap. Irrespectively, the principles remain the same, where the wrap has to be a partial and tension free, and it should cover your myotomy site without creating any obstruction. So this almost completes the wrap creation, and the next part is to have a adequate hemostasis, and you have to do a check endoscopy to. So to summarize, first obtain a good exposure before starting the anatomy. Second, identify the G junction. Third, preserve your anterior vagus nerve. Fourth, divide the muscles completely while staying close to the submucous plane. Fifth, ensure adequate extension both proximally and distally. And sixth, check for the mucosal integrity. And finally is your loose wrap creation. Thank you for watching Inside the OT. If you found this video useful, do like, subscribe, and follow for more. I'll see you on the next one.